And so we
Question.
yes.
Regarding the HCI that we take at the end of the semester, is it like everything we've learned all semester? Because
No,
it
it's
just
just
says
gonna be
pediatrics,
peds.
so
It's
it's
just
just
gonna be
peds. Okay.
Okay. All right. So let's talk about the at-risk newborn and neonatal and pediatric development. Now, I have to apologize. This is not my strong suit. I have always been anti-NICU, and so I'm going to have to struggle with this a little bit, and you guys are going to have to read on this more than I can help. Okay? Before we begin, let's take a quiz. I forgot.
That's going to be fantastic.
That's wonderful. Let's pause the recording and take a quiz.
We're going to have research paper, presentations, and exam due the next day.
I'm lucky I'm such a fat guy. Because you know why I thought to take a quiz? Because like, man, I'm hungry. Why am I so hungry? I was supposed to eat those crackers. Oh, I was going to eat them while they were taking the quiz. And that's why I remembered that you guys have to take a quiz.
I tried it, yeah. I'm not going to eat more.
It's on the schedule.
Whatever day is listed, anytime after that is 10 minutes.
You guys look on the
He just emailed it to us.
Can I take her out of the class? Anybody not get a quiz? Okay, take a quiz. And I'll eat my crackers.
Okay, you eat your crackers. Oh. I'm sorry. That's just not what I expected to see.
You don't want to keep them until we grade them?
Oh, is that what we're doing? I'm like, I haven't eaten yet, I don't know what's going on.
Do we need more time? You have to go potty?
Yes.
Well, then go.
I want to wait till we read it.
Okay.
If she pees on herself, I'm like, yeah, I'm not sitting in that chair.
I'm actually 5, okay? It's fine. Let's just get
I
this.
recognize that. All right, so let's go before Evan pees on herself. All right. Question number 1. The pediatric nurse is receiving morning report via its phone call on an infant who will be arriving in the neonatal intensive care unit. The nurse indicates a shoulder dystocia may have occurred during the birth process. The nurse assesses the neonate is at risk for which additional condition? A. Brachial plexus injury. Yep. Hyperbilirubinemia, hypoglycemia, and intracranial hemorrhage are not common complications of shoulder dystocia.
You want us to like mark it?
No, don't mark it. Otherwise, you guys would all get the right answer, right? The premature infant has not had a bowel movement, and the nurse assesses abdominal distension after the last feeding. What action by the nurse takes priority? D. Place the infant on NPO7. Haha, you haven't read your chapter on prematurity. The important thing is this is a premature infant, okay? And a premature infant with abdominal distension is at very high risk for bowel disorders. And so if you continue to feed him, you're going to have a problem. So this is one of those things the food is considered a medication in pretermers. So this is the same thing as a patient who's on a beta blocker whose pulse is 40. You would hold the medication, okay? And so that's what you're going to do. You're going to hold this medication and get with the doctor. Yes?
So I didn't read, no. But I guess when I was answering, I didn't know that the nurse was allowed to do that, like place the infant on NPO. But I thought the
Right.
doctor practiced.
And that's covered in the chapter that food is more of a medication. What's that?
It's just been a stressful week.
Yeah, I understand.
So why not call the doctor? Why is that not right?
You will, but the first thing you're going to do is hold the feeding, then you're going to call the doctor. So the priority is to hold the feeding, not to
But
feed
it
him
doesn't
first.
say hold the feeding, it said put him on NPO status.
Which is hold the
Technically,
feeding.
you can assume that that's how you do. They had a bowel
Remember when you
distension.
see this on the test? Hold the feeding. Put it on NPO. Okay, a nurse is seeing a baby diagnosed with a cleft lip. What assessment finding indicates to the nurse that a priority outcome has been met?
Weight gain.
Weight gain, exactly. Because cleft lip, the most important problem is difficulty feeding. Okay? Yep. A pediatric nurse examines a 7-year-old at the well-child visit. Based on Erickson's theory, which basic task does the nurse anticipate for this child? B. Now, when you're learning these various developmental theories, pay attention to the goals of the theory. Okay? Yeah. Pay attention to the goals of the theory. The Erickson's theory says that a 7-year-old should be able to develop a sense of confidence through mastery in developmental tasks. And I always have to look this up specifically, but it is, the goal is called, it's initiative versus guilt? No. It's accomplishment and industry versus inferiority, where the child develops a sense of confidence through mastery of tasks. A parent is frustrated with a toddler and wants to do everything on her own, in his own way, instead of in my way. The parent wants to know the appropriate way to discipline the child for not obeying and allowing the parent to dress him quickly in the morning. Which response by the nurse is most appropriate?
Charlie.
B.
It's B.
Yes.
I heard your voice. Did you hear his voice?
I wrote C, but I know it's wrong.
Yeah, see, but I know it's wrong. Put him in timeout because he's 2, and he gets 2 minutes of timeout. What's important to understand is that a 2-year-old, a toddler, has to do it their way. They have to develop, they have to do it. I want to do it. I want to do it. And that's why you always see toddlers in like mismatched shoes and buttons all crazy wrong. And the parents are like, this is what they wanted to wear. Right? Yeah, because every day is a costume party for them,
My
right?
favorite is when I do like the little, we call them flip-flops growing up. We do those little like dress-up shoes that are super uncomfortable.
Yeah.
But like the little girls want. My favorite is when you walk through Walmart and you see them wearing that. I'm like, oh, she dressed herself.
Exactly. So it's important to know, I know it's frustrating, but being independent is a very important job for a toddler, okay? And the last question, a couple brings their child to the Well Child Clinic for guidance on improving the child's school performance. The nurse assesses the child and finds his favorite activities are running, playing basketball, and building models. Which conclusion is most appropriate for the nurse to make based on the assessment findings? B, that this child is a kinesthetic learner, right? That he has to learn through body involvement. And you can save this child an awful lot of stress if you simply teach the parents that not everybody is book smart, okay? That some people need to learn in different ways. Pass your quizzes then to the side, and I'll come by and pick them up. What?
Are they worth half a point?
Yeah, half a point.
Go.
He totally told y'all don't mark on the sheet. Anyway, I can. Anyway, I can.
30-second tea break if you need it. I don't want to get UTIs.
30 seconds.
You know there's only 3 stalls in there, right?
What?
There's only 3
And
stalls.
most of us don't kiss them. Yeah, I
What? I have nothing on this. We'll do an email or we'll use Turnitin.
I think he sent a code in email.
Oh, email or
I will try to have it fixed before the end of the class.
what? What's broken?
Not if we have it a week.
Well, it's been real.
Yeah, we have the Turnitin.com.
I don't have the email ID.
Okay, I'll forward this to you.
I'm telling you. What tournament?
Maternal paper. The maternal paper has to be turned in now to Turnitin.com.
Okay, so
So wait,
now we will start.
I'm really not done with my maternal paper anymore.
Oh, oh.
Really?
Sorry about that. Okay, back to the question at hand. So, quiz is over, and now we can begin. So, like I said, I'm not an expert in caring for the high-risk neonate. Sometimes I wish I were as smart as my wife, but I'm not. So I can't.
Are there stuff on Blackboard
lab tomorrow? If it is, then it's up to to Professor Matthews to put it on there, and it should be there under the course documents. Okay. So, some things you need to remember when you're caring for at-risk newborns.
Before you get to, you wasn't talking about the paperwork, you're talking about is there any articles or stuff that you wanted to read that there happened for the previous?
No.
Okay.
Ms. Matthews is running the pediatrics labs, so I haven't done anything with them at all. Okay? So, important things to remember, that babies have, they struggle with immature respiratory system, especially when they're premature, okay? We mentioned this briefly in the lecture, in the test review last time. It'll be more prevalent this time. But the LS ratio and the PG are both going to elevate toward the end of pregnancy, and they're markers, and you can use them in the amniotic fluid as markers for a high chance of having mature lungs. Okay, circulatory system, remembering that there are 3 shunts that have to close, and that the newborn does not have the ability to make his heart beat harder. Okay, if we get exercising, you feel your heart thudding in your chest. A newborn can't do that, okay? They don't develop a bounding pulse. The only way they can increase cardiac output is by increasing the rate, all right? So if you see a baby with an elevated heart rate, it means he's struggling to get enough oxygen to his body, and that's the only way that he can accommodate. He can't make his heart beat faster. He can't increase the stroke volume. He can only increase the rate, okay? And the neurologic system, it's important to remember that they're neurologically immature at birth, and that they're not as developed as other mammals, and so they can't respond the way we would to different stressors. And the big thing we worry about in premature babies is that they can't handle external stimuli. And so around a preterm baby, you always have to be very, very quiet. If you ever get into a NICU, it is the quietest unit in the hospital. There's like no talking in a NICU. It's very quiet all the time.
Because of the stimulus?
Because babies can't handle the stimulus, yeah.
Because you may think about it, they're in this nice little comfortable
So in prematurity, we're trying to create the womb, okay?
Wow.
A nice, stable, quiet place where the baby can be okay, all right? So let's talk a little bit about classification of newborns. I posted an article, it's 1 page, extremely easy, talking about completed weeks gestation. Did anybody happen to read that? Probably not. Okay. So does anyone understand what a completed gestational age is, or what it means when we talk about 36 completed weeks?
It's like 30 to 30.
Okay, so how old, if a baby has completed 36 weeks, what is his gestational age?
37.
Nope, 35 and 6.
35 and 6.
35 and 6, okay? Because
At 7, it would be 30.
at 37,
It would be a
they
new
are now
week.
in their next week, right?
Yeah.
So when this is very confusing for us to understand, and every OB provider struggles with this, okay? When they talk about when we use gestational age for prematurity or for anything else, we're talking about their completed weeks gestation. So if we say he is 36 completed weeks, we don't mean he's 36 and 6 going to 37, okay? We mean he's 35 and 6 going to 36, okay? And the way that I remember it is if your baby is 36 and 3, he is 36 weeks completed plus 3 extra days. So any time spent in the following week is the next week, okay? He is in his 37th week. So a baby who is 36 and 3 has completed 36 weeks and entered 3 days into the next week, into his 37th week.
So the baby's
So-
36 and 6.
Right.
They completed 37 weeks.
He has completed 37 weeks, exactly. Because
But if they're-
tomorrow he will start his 38th week.
But if they're born on 36 and 6, they're still premature.
Well, they're 36 weeks and 6 days old. No, they're not premature. 36, and this is very hard to wrap your head around. So if you're going to use 37 weeks as 37 completed weeks for prematurity, then yes, 36 and 6, he's 1 day short of 37 completed weeks. So he's completed, he's in his 37th week, right? So 36 and 6 is in the 37th week. And at 37 and 0, he has entered his 38th week.
So he's good.
Right. So it's very, very confusing. And you're not going to see a question on the test about it. But it's important to understand. When we say that a baby delivered before 38 weeks means in his 37th completed week, okay, or beyond. So that kid is, through the 37, like 37 and 6, is still premature. He hasn't completed his 38th week yet. Yeah.
Okay. I was born at 36 and 6.
Right.
That was when I was born.
So you completed.
So I completed 37 weeks.
You had completed 37 weeks, yes. 37 and 0 is the next week. Right.
So I wasn't considered premature.
Correct.
Okay.
But they.
Your whole life is a lie.
It is a lie. It is a lie.
And that's okay. This blows everybody away. And I even struggle, you can tell I still struggle with it, right? Because I want to say that until you say 38 weeks, you're premature. But you complete your 38th week at 37 and 6. Okay? So, yes.
Do you consider 42 weeks abnormal?
Yes, it's a problem. Yep.
Is it abnormal?
Yeah, it is abnormal to make it past 42 weeks. There's a reason they made it past 40. And this is where a lot of people get confused, like with the induction criteria, and they say that you induce in the 42nd week. So people say, well, that's 42 and 3. No, the 42nd week is 41 to 42, 41 and 0 to 41 and 6. That's the 42nd week. Okay? And that's where there's so much confusion and why people go, whoa, 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 whoa. No, you say you induce at 42 weeks. No, you induce in the 42nd week. Okay, which
So it'd
is
be
41 and
41 and
1. Yeah, 41 and 0 to 41 and 6.
Because if it was 7, it'd be a new week.
Exactly,
Because
that's
the week has
because
7
they're 42, now they're in their 43rd week. And I always get confused,
Good work.
do you start by saying and 0 or do you start by saying and 1? It's 37 and 0 to 37 and 6. There is no 37 and 7. 37 and 7 says the next week, so that's 38. So it's 37 and 0 to 37 and 6 is that week, okay? And that week is the 38th week. Okay?
Okay, I'm lost again.
Definitely.
I think I got
They
it.
weren't saying anything out of them.
Bonus question.
Yeah, right? There you go. How many completed weeks has this infant faced? Okay.
Really, Anita?
So for gestational age, there are preterm, term, and post-term, right? And preterm has been further stratified into early preterm, late preterm, near term. Well, they used to say near term, they got rid of it and changed it to late preterm. And there are ways of thinking about how far along the baby is. The reality is that when a baby is born, you assess what care they need and you treat them appropriately. Okay? So a preterm delivery is any baby delivered at or before the completion of 37 weeks gestation. So that's 36 weeks and 6 days and before. They have not completed their 37th week of gestation. Okay? Term babies are any babies delivered from 38 to 41, and post-term babies are any babies delivered after or on or after their 42nd completed week, which is 41 and 6 and beyond. Okay? Now the reason that post-term babies are a problem is because the placenta gets old. It's beyond middle age and it's worn out, and so your risk of intrauterine fetal death goes up dramatically after 41 weeks. And also babies, they tend to have more meconium aspiration syndrome, they tend to have more IUFD, they tend to have more shoulder dystocia. There's a difficulty. And if you made it that far in your pregnancy with correct dates, there's a reason that baby hasn't been born. Okay? There's a block in the way somehow. Too big, too small, funny shaped head, pelvis is bad, whatever. There's a reason for that. And so, from 41 weeks to from 41 and 0 to 41 and 6, you may as well just move toward induction because there's a reason they haven't made it that far yet.
Does that increase the, like the C-section? and
It
the-
doesn't, because anyone from 41 weeks, 41 and 1 and beyond, already has a high risk of C-section whether you induce or don't induce.
But the
Because
baby keeps growing, right?
it grows very little in the last month, okay? So the growth kind of stops right around 38 weeks. You can't tell a 38-weeker from a 41-weeker just on size,
Okay.
okay? They really slow down. I always say the baby grows to the size of the fishbowl they have, and then they stop growing.
Okay.
And so people are like, oh, he was 38 weeks, but you know, gosh, if I had made it to 41, he'd have been the same size. Maybe a half pound bigger, big deal. Okay. So, birth weight. 3 categories of birth weight. Low birth weight, very low birth weight, extremely low birth weight, okay, on the low hand side. So, a low birth weight baby is any baby under 2,500 grams. Very low birth weight, any baby under 1,500 grams. And extremely low birth weight, any baby under 1,000 grams. 1,000 grams is 2 pounds. Okay, they're usually that size by 20, 26, 27 weeks. Okay, yes.
If a baby is born at like 3 or 4 pounds, like considered twins, is that still healthy?
They're still low
if they
birth
don't-
weight.
But would they have to go to the NICU, or would that just be? Like,
Depends on how they are at birth.
So that's what I'm saying, like, does birth weight dictate, is a factor in going through?
So
Like, if they were
any
completely
baby
healthy.
who would be under 2,500 grams gets a NICU evaluation.
Okay,
And then the NICU determines whether or not they're safe to go to the term nursery or not.
okay.
Okay.
So if they're healthy, they're just really, really small because they were twins or whatever reason, they
Right.
just go to the healthy nursery?
They
Just-
can, they can. And it becomes a very difficult judgment question. Babies who are who are late preterm, 34, 35, 36 weeks gestation, or babies who are closing right around 2,500 grams, they are more likely to get sick. Okay, and so if you've got a mother-baby unit or a family-centered care unit that is very tuned in to those babies who are on the threshold of health, then they'll do really well there. But if you've got a unit that isn't, then they're going to be forgotten. Okay, we call those babies the great pretender. They look very normal. They're just not quite ready to be on the outside yet. And so they get readmitted very often. Matter of fact, 75% of all newborns who are readmitted to the hospital are 34, 35, 36 weeks gestation at birth. Because they're not quite ready to be outside, and they eat just a little bit more poorly than other babies. They maintain a temperature just a little bit worse than other babies, and they need a little extra nursing care. The problem is, do they need to be in the NICU 24/7, where mom doesn't have access to her baby, where you have to schedule feeding times? Probably not. And so you have to find out what the best place is for those babies. But as a general rule, any baby who's under 2,500 grams needs to be very carefully monitored, much more carefully monitored than the gestation age would suggest. Okay. Now, intrauterine growth restriction, IUGR. Okay. Intrauterine growth restriction means that there is something wrong in the uterus that caused the baby not to grow very well. This isn't a baby who's a twin and just a little smaller than another twin. This is a baby who's not growing effectively in the uterus because the placenta is not functioning well, or there's a hostile uterine environment of some sort. Okay. I thought it was a funny statement. Usually results in small for gestational age newborns. Duh. If they're small on the inside, they're going to be small on the outside. But the reason that this is an important statement is to understand that before a baby is born, the phrase is IUGR, okay? And it's a guess, because ultrasounds are not very accurate. At term, an ultrasound can be off by an entire pound, okay? That's a lot. An entire pound is 480 grams. In a baby who's 25 to 3,000 grams, 480 is a way off, right? But in a baby who's, 4,000 grams, 480 is only 10% off. But they can be way off in utero, because the ultrasound doesn't measure the baby; it measures their skeletal structure. Okay, it looks at the length of their humerus, the length of their femur. It looks at their abdominal circumference, but it's not really looking at their baby itself. And it has a hard time understanding body fat and that kind of stuff. It can't look at the biceps and go, oh, those are big, chunky, fat biceps. Or look at those cheeks. You can't do that on an ultrasound. You measure the abdominal circumference, the head circumference, the femur length, the humerus length, and one other. Biparietal diameter from ear to ear. Okay, so ultrasounds are not very accurate. So we make assumptions, we get as good as we can, and it's based on how good the ultrasonographer is. But and then, you know, so we'll deliver a baby for suspected IUGR, and then they come out normal size. So like, oh, well, we tried, we thought, maybe. Okay, so it usually results in an SGA infant, but not always. Now, so IUGR is intrauterine growth restriction. SGA, small for gestational age, means he's on the outside. Okay, and so the distinction between the two is one is intrauterine and one is newborn. Okay, and they just changed titles. You would never see IUGR in a NICU. You would see SGA, okay, or very low birth weight. But you wouldn't see IUGR because they're not intrauterine anymore. So SGA infants or any infant born at any gestational age where they're below the 10th percentile on the growth chart. So you've all seen growth charts for kids, for children, right? From birth, they mark how many days old they are, then how many weeks old and months old, and you watch it kind of grow. We have the exact same growth charts for the intrauterine environment as well. That a baby at this many weeks gestation should be this weight. And the 90th percentile would cover this range. And so when they drop below the 10th percentile, it's considered IUGR. Okay?
Anything about that too? No?
And by the way, you guys, never mind. So babies who were born SGA tend to look like this, right? They tend to have wasted muscle tissue. They're like all skin and bones. Not a lot of fat, not a lot of brown fat. And it's important, if they don't have brown fat, what do they not have?
Heat, insulation.
Heat, temperature. They don't have their ability to maintain their own temperature. That's a big deal in a newborn, right? The abdomen is often scaphoid. It's sunken in. They look a little bit like they just look like they're starving, okay? Because they are, right? They've had a lack of nutrition. That's why they're SGA. Their eyes appear large in their head. Their head is large too, but their eyes like bulge out of their head, and they look like a wise old man, okay? Their fingernails are often long, and they tend to have meconium stained cord. Why would they have meconium staining on their cord if they were SGA? Any idea?
Because they have it in
Well, because they had it in utero,
Yeah.
right? But when their skin and their cord is stained, it means it's been there for a while, okay? And so one of the theories of meconium, passing the meconium prematurely, is that the baby's under distress. And so when we see babies who are under distress, they almost always have meconium-stained fluid, okay? This is not a baby in utero, or in labor, who's under distress. This is a baby who is under a physiologic stress before labor. Okay, so babies who are IUGR tend to have a lot of meconium-stained fluid. Babies who are post-term with a bad placenta tend to have a lot of meconium-stained fluid. So you will tend to notice meconium staining either of their skin or of their umbilical cord, and it just means that they had meconium-stained fluid.
I'm making sure it's saying meconium happens.
Yeah, meconium happens. Oh, that's a very common one. And then another one, and this is a little contradictory to what I just said, that meconium, scientifically speaking, meconium-stained fluid means only one thing, and that means that they have a patent anus. That's all it means, okay? All it means is that the butt works. Okay? We certainly see it in stressful babies, but we can't say that was a stressed out baby because he had meconium-stained fluid. All we can say is that the butt works. Okay? But what we often say is, well, it doesn't surprise me he has meconium, you know.
Right.
But it's not diagnostic. So things that they struggle with, because they have no fat, they have these wasted muscles, they struggle with cold stress. They struggle with pain. One, because of all the interventions, and two, because they're malnourished to begin with. They have problems with hypoglycemia, obviously, right? If they had glucose stores, they wouldn't be malnourished, okay? And they struggle with polycythemia, which is a high venous hematocrit. Okay, and the reason for that is because their hematologic system works well, but their body doesn't, right? So they've got all the blood they need, they just don't have the body to support it. Now, on the opposite side of that is large for gestational age, and that's babies born over the 90th percentile. As a general rule, that's right about 4,000 grams, which is 8 pounds, 14 ounces and above. Yes?
I'm just curious, like, when they have that, do they always test for diabetes?
The mother? Not necessarily, no.
Because
They test the baby's blood sugar to make sure that the baby's blood sugar is stable, because it could have been an undiagnosed problem with the mom. But we don't test mom for diabetes, because if she had diabetes, the cure is to deliver the baby, right?
Yeah.
So done. If she had diabetes, she doesn't anymore, move on. So babies, but they can also be genetically large. Okay, one of the biggest babies I ever had was like 12 pounds? No, 11 pounds. My top two babies, one was 11.14 and the other was 11.8. Now my 11.8 baby was born of a mother who was 6'6" and a father who was 6'8". If these two gigantic people had a 9-pound baby, I'd assume he was premature, okay? Because they were enormous. If you've ever met any Samoan women, they are very large people in general, the Samoans are, and their babies are very large too. So it could just be genetic. Now, if you got a mom who's 5'2" and weighs 100 pounds, and she has an 11-pound baby, that's a problem, okay? That ain't normal. But if you got a mom who's 6'6" and weighs 200 pounds with an 11-pound baby, well, that could be okay, right? So it's not the size of the baby that matters, it's how well the baby fits with the mother, okay? So any baby over 4,000 grams, or over the 90th percentile for gestational age, we treat them as LGA with the understanding that it might just be normal genetics. We're still going to watch them, but it might just be normal genetics, okay? But you'll often see babies who are over 4,000 grams, usually it's because they've had an imbalance of nutrients, that they're growing too much because they've been exposed to too much sugar. And I always say, if I were surrounded by cookies and ice cream all day long, I'd be pretty big too. I'd be in the 90th percentile, right? So babies are given the nutrients from their mother, and they get big based on how much nutrients their mother gives them. Now, I thought this was a neat pain scale for premature infants. What's important to notice is what happens as the baby gets more pain, okay? That a baby who's in pain, and notice that it goes down. Gestation, they get more points for being premature, right? So your 28-week infant automatically gets 3 points on the neonatal pain scale. The assumption is he's already more sensitive to pain than a baby who's 37 weeks or beyond, or 36 weeks or beyond, right? So, but notice that as they start to get pain, their behavioral state increases from active and awake all the way up to active or sleeping. Why would a baby sleep? Any idea why a baby in pain would sleep? Have you guys ever seen that?
There's nothing else left to do.
They quit.
Yeah.
Exactly. So they get up, they get to, and they just shut down, okay? And that's a baby who has given up, okay? Because he's neurologically immature. He hasn't the ability to continue to scream, okay? His body can't handle it, and so whenever it's hyperstimulated, it just shuts down. It's like your computer freezes and you have to reboot it, okay? So NICU nurses hate when the babies stop crying, because if they're doing a procedure and the baby stops crying, they have pushed them too far, okay? And they always feel very bad, okay? They're going to continue on and do their procedure because now he's not in pain anymore, but they feel bad that they caused that much pain. And you see that with adults too. You know, when I ran my scooter in the back of a car and broke both arms in 12 places, I passed out. Right? I had severe pain, and my brain said, that's enough, done, right? And so the same thing happens with babies. You'll notice the heart rate increases, right? 5 to 14 beats is a little bit of pain, 15 to 24 beats a minute is moderate pain, and more than 25 beat increase is severe pain, just like you would see on us. That the O2 sats decrease as they go through more pain. And then there's brow bulge, this and this as eye squeeze, and nasolabial furrow is this, and that's when they scream and their lips go, and they push together and make a little dent in here, okay? That those are all going to increase as well, okay? What's that?
Brow bulge.
Brow bulge.
Okay.
Their brows
I'm
bulge
gonna read
out,
that
their
next.
eyes squeeze closed, and their lips come out. And those are all signs that they're in more pain. Okay? By the way, I am not going to ask you, this baby in this picture has an infant pain scale of what? Okay. But you might see that you have an infant pain scale of 8. What would you do, right? Try to eliminate the pain. Okay? Okay, so conditions affecting LGA newborns. Babies who are LGA, obviously, they could be born from a diabetic mother, so they've got problems with their blood sugars. They could have transient tachypnea of the newborn. It's a very common problem to have delayed clearance of the fetal lymph fluid, and so they get these transient periods of tachypnea. And they just all of a sudden will be breathing 60 to 70 times a minute, and then it'll kind of settle down. And the important thing to understand about transient tachypnea of the newborn is transient tachypnea of the newborn is transient. It's benign. It's not harmful. But the problem is, how do you know it's TTN versus sepsis? How do you know it's TTN versus hypoxia? It's difficult to know. Okay, so we respond to babies with a respiratory rate greater than 60 with the understanding that that might just be a benign normal finding, but we have to rule out all the other problems first before we can say that. And hypocalcemia, that their calcium level rises and the drops. And then low calcium babies can have seizures. Okay, hypomagnesemia, these problems. But the big thing you're going to see is birth injuries and brachial plexus injuries and fractures. Okay, understand that birth is squeezing a big item through a small hole, and so the bigger the item, the more likely you are to damage the baby. Right? So babies who are LGA have more birth injuries, and all of these fall into the birth injuries, brachial plexus injuries and fractures. Brachial plexus, if you drop your shoulder all the way as low as you can, you'll feel that your arm starts to go a little numb, right? You feel a little bit of pressure in your forearm, and your fingers will start to go numb. Then turn your head all the way to the other side. Do you feel that pain in your arm? Yeah. Very uncomfortable, right? That's stretching your brachial plexus.
That's a mammogram.
That's a mammogram, is it? Never had one. But yeah, they do. They make you turn your head. I thought they just put your breast on the plate and squeeze it down.
You gotta maneuver on it.
Huh?
Depends on the size of it.
But what's important to understand is that if you do that to yourself, you can understand how a baby with shoulder dystocia, where he's being born this way with his head turned, is going to cause problems with that brachial plexus, right? And that's the brachial plexus that goes from the cervical spine through the shoulder and up under the arm, okay? And so brachial plexus injuries are very common in shoulder dystocia because of that prolonged stretch as the head was out and the body wasn't, okay? The shoulder wasn't. The other one that you'll see is fractures. The most common fracture is in the clavicle. Okay? So a clavicular fracture is very common as the shoulders get squeezed to go through the birth canal. They break the collarbone. Babies will favor that arm and be like, eh, and every time you touch it, they'll complain a little bit about it. Not nearly as bad as if you broke your collarbone, but they will complain about it. And so it's part of your assessment, especially if you see you got a baby who's LGA, you want to rule out brachial plexus injuries and fractures. And the easiest way to do that is look at how they're carrying their arms. A baby like this is doing okay. A baby like this is not. Okay? So if you see they're uneven in their hands, they could have brachial plexus injury, or they could have fractures of their collarbone or fractures of their humerus. Okay? One of the maneuvers for relieving shoulder dystocia is babies in here like this. We sweep in and grab the arm and rotate the arm through like this, kind of swim them out. And when we do that, if we don't catch the arm well, we could break the arm as we try to move it. And so babies are born with a broken humerus from time to time. And then another common break is babies who are breech can have long bone fractures of their thighs. So they can actually break the humerus at birth. Now, understanding, babies don't have the same bones that we do, right? They're kind of flexible. They're squishy, right? They've got more cartilage than they do bone. So they can handle bone fractures better than we can. Okay? They recover easier most times. And then prematurity. So there are different types of prematurity. There's severe prematurity, moderate prematurity, and then the late preterm infant, okay? And they're broken down, as you can see, in gestational age, from 23 to 26 weeks, 26 to 34 weeks, and 34 to 37 weeks. By far, the largest category of premature infant is 34 to 37 weeks, okay? Most babies who are born prematurely are born between 34 and 1 and 37 and 0, which is before the 36th completed week, right? So 36 and 6 is the 36th completed week. Okay, but that's where most of them are, and those are called those are, like I mentioned, those are the great pretenders. Those 34, 35, 36-week babies are about 3,000 grams. They look pretty good. They cry at all the right times, but they're just lazy feeders, and they struggle with keeping their body temperature up because they're just a little bit premature. They're not quite ready to be out. And those babies used to go right to the normal nursery, okay, and then be readmitted to the hospital 4 days later because nobody noticed that they weren't eating very well. Okay, so nowadays we pay very close attention to our late preterm infants. For a short time, we sent them all to the NICU, and then we realized, if we just train the nurses on mother baby, we could get better outcomes without sending them to the NICU. So we now recognize those babies as special. We pay more attention to their feeding and their temperatures and their parenting skills, making sure the parents understand he looks normal, but he ain't normal. Okay, treat him a little bit more special and make sure you come back in 48 hours for your checkup. So they just need a little extra monitoring. They don't necessarily need to be in the NICU. Okay. Now, so physical assessment of the high-risk newborn. Your book has a wonderful chart on physical assessment of the high-risk newborn. It's chart 19.6. It talks about or table 19.6. It talks about all of these things. Okay. I'm not going to belabor it too much. But understand that their skin on premature babies tends to be a little bit thinner, okay, more fragile, easier to break down. That you can see gaps between their ribs. They have these real skinny ribs. They tend to look more purple than they do pink, and that's not uncommon. That their head appears large, and their heart is just a little shifted toward where was the heart? Apial heart. Where is it? The heart auscultation is done at the 2nd and 4th right and left intercostal spaces. Okay, right here. Okay, because remember we talked about as the newborn ages, their heart comes down into their chest, so it's very high on a premature baby. It hasn't even gotten down to the normal spot for a newborn. It's still very high. Okay. What else? Musculoskeletal. Do you think that a baby born at 26 weeks is going to have good tone or bad tone? Bad tone, right? So he's not going to be up like this like a normal newborn. He's going to lay in the bed like this, okay, most of the time. So they're going to have poor musculoskeletal tone, and they're really spindly. Okay? And if they're very premature, 23 to 25 weeks, they're covered in hair. Okay, they have a lot of lanugo. They look like little baby monkeys. They're kind of cute. Those little Capuchin monkeys, that's what they reminded me of every time I see them.
I think of Monchi-Chis.
Okay. Their genitalia are going to be a little bit different. I never went through the Monchi-Chi phase.
Oh, no.
So the genitalia are going to be a little bit different. They have no rugae in the male scrotum. They're very smooth. And in the female genitalia, they have a large clitoris that's not covered by the labia. So they look odd. And it's just because they haven't finished maturing yet. And like we talked about neurologically, they're very immature and they're very sensitive to stimuli. Now, your book talks briefly about the stable program. Stable program is primarily a transfer of newborns, but it's a good way of thinking about the high-risk newborn. Okay, that you think about their sugar, their temperature, their airway, their blood pressure, the lab work that you need to support, and the emotional support of both the baby and the mother. Okay, so like I said, it's written from transport. If you're a mother whose baby is being transported to another hospital, do they need emotional support? They sure do. That's a baby who's sick, and mom and dad are scared, right? So that's where that comes from. But it's a good way of thinking about the care of newborns. What's his blood sugar? What's his temperature? What's his airway? You know, what blood work? What's his blood pressure? What lab work do I need to make sure I know? And what am I doing to take care of mom? Okay. Now we'll talk a little bit about meconium aspiration syndrome. What is meconium aspiration syndrome?
Sounds like he inhaled his poop.
He inhaled his poop, right? Okay. And that's a big deal, okay? Because does poop belong in the lungs? No. Is poop sterile? No. So he now has a source for a bacterial infection in his lungs, okay? And about 1% of term newborns who have meconium stained fluid will have meconium aspiration syndrome. Why not all of them? Because they have vocal cords. And their vocal cords protect them from foreign bodies entering the lungs. Okay? They're breathing fluid, so that's why they have a risk of getting meconium in their fluid in their lungs. But the vocal cords stop the meconium from coming in, allows the amniotic fluid, but not the meconium. Okay? So it's lucky for us, right? The universe protects babies and pregnant women. And so, so most babies with meconium stained fluid will not have meconium aspiration syndrome. But as soon as a baby who has amniotic, no, has anyone seen a birth with a meconium stained fluid baby?
I think my NICU baby, had
He had meconium aspiration syndrome?
oh.
Or he just had meconium fluid?
They took him right to the.
That was that 25 weeker they used to? Yeah, okay. So when a baby is born with meconium stained fluid, in the old days, we used to, as soon as the head came out, we'd pass a suction catheter up the nose and down their throat and suck out their upper airway to make sure that when they went, that they didn't get a gasp of amniotic fluid, okay? Or a gasp of meconium stained fluid. Now we know that that doesn't help. And so babies who are born with meconium stained fluid, if they come out and they're kicking and screaming and vigorous, then we say, okay, he's fine. He obviously doesn't have meconium aspiration syndrome. Okay? But if they come out and they don't aggressively breathe, then he might have meconium aspiration syndrome, and he needs to go to the NICU team immediately. Not to the NICU itself, but every time there's a meconium stained fluid, you're going to have a baby, we're going to have a NICU team there standing by, ready to take care of this baby just in case. And so the baby comes out, he's not kicking and screaming and healthy, we cut the cord immediately, pass him over to the NICU team, who immediately looks down his throat with a laryngoscope and looks at his vocal cords. If they see meconium below the vocal cords, then the baby's in trouble, he's going to go to the NICU. If they don't, they just suction out to the vocal cords and beyond. Yes?
What color is the meconium stained fluid? Because I'm thinking
It's usually green to black.
Because my baby the other day had some like yellow chomp coming
That's-
out, and she had meconium. She also had GBS.
Mm-hmm.
But I was trying to figure out why it looked.
Yeah. Anything that's not
fluid-filled?
that's not clear is meconium stained fluid until proven otherwise.
And she did. She
Yeah.
went on the doctor's pamphlet. That's the one that had the variable prolonged.
Oh yeah, yeah.
She.
Yeah.
Okay.
Yep. And so yeah, so they'll you know, if it's just a little meconium in the amniotic fluid, it'll be kind of a yellowish look. The more meconium is there and the longer it's there, the darker it gets.
Okay.
Okay. So you know, because it's more concentrated. So if we see anything but clear fluid, we want to assume meconium stained fluid. We used to talk about particulate versus not, and you'll still hear people say, oh, that's thick mech. Oh, thick mech. And like, it doesn't matter. It's either mech or not mech. Okay? It doesn't matter how much. There's no quantification. It either is or is not meconium in the fluid. Okay? And they always think, well, if there's more, if it's thick mech, they're more likely to have mech aspiration syndrome. No. It either is or it isn't. You can't really qualify meconium or quantify meconium. Okay? So babies born with meconium aspiration syndrome tend to have meconium stained skin, nails, and umbilical cord. What does that mean if they've got meconium stained skin, nails, and an umbilical cord? It means it's been there for a long time. They've absorbed it. They've been living in this for a while. Whereas babies who just pooped during labor, their skin isn't stained. They don't look like they're covered in poop. Okay? But these babies, they've been in there for a long time. Okay? They'll have a little initial distress, then they'll get better, and then they'll get worse at about 12 hours old. Okay? So, so any baby who had meconium stained fluid, you're taking care of in the mother-baby unit, he's less than a day old. You have to really be paying attention to his respiratory assessment, because they'll do better. They have a little respiratory distress initially because they've got that stuff in their lung, but they recover, and then the bacteria starts to grow, and they start to get the aspiration symptoms. Okay? So it takes a little while for that to set up.
You said
They have
12
a-
hours is that timeline.
About 12 hours, yeah. They have barrel-shaped chests from being overinflated, from struggling to breathe with these damaged lungs. And of course, they have adventitious sounds when you listen to them. Okay? And the only way to diagnose it is a chest x-ray, where you see patchy infiltrates and atelectasis. Nursing care is aggressive chest CT. Help them move that stuff out of there. Oxygen usually via CPAP, which is, what is CPAP? Continuous
Pressure.
Yeah, continuous positive pressure, right? So that's the thing, like if you have sleep apnea, you sleep with a machine, that's CPAP. It's just a constant pressure to keep things open so they never close. Okay? They give them medications, they give them both, Pavulon to help with the ventilation. They give analgesics and sedatives because they're going to be on a ventilator, and they're going to give them morphine for pain to keep them from fighting the newborn, from fighting the ventilator. Okay? Let's take a break. You guys are like sleepy, you're like dying. This is a low energy crowd. Too many people up late last night working on papers, huh?
Yeah, I need to go to bed, it's like 9:30.
Yeah. I was in bed by 10 myself, and I'm never in bed by 10.
9:30?
9:30.
Don't brag.
That's rough. That is that is what I'm hearing. Good question. I heard it on the grapevine.
That's
Yeah, that you have to wait 24 hours to get a second finish.
What about the 28th? It's a Saturday, but like that day. So during the day. Oh, I know. No, it's a straight.
No, it's just a random person.
Someone I work with.
I don't think it's she's not gonna tell you.
I don't think that considered an article, that would be a guideline, right? Yeah, it's a guideline. So do it as a guideline, there's a guideline usually. There should be fine though. And be like, I know you said article, but I'm using more health instead. It should be fine. The scholars is ours.
I'm really gonna cry because of email. I'm really gonna cry.
You really have it. Now or in the past?
I appreciate that.
It's someone that used to go here on Monday.
for salmon. For salmon? Yeah, it's usually we do.
So you guys have similar? What?
And then I'll be
That's all that gassy.
sorry.
How about the food around house?
Hey, Justin, you have to decide to see how you do
The pretzels are
And I didn't name them yet? Is it you? Nancy! I was silly.
You'd be a good wife.
What?
She said she'd been working on my paper last night.
Maybe lunch, got me snacks.
So sweet.
I married her.
Mary, you better proper. I was fixing my lunch instead of working on my paper. I got distracted. I kept thinking about
I was so
what
mad.
I wanted to do.
Last night I got home and I was like, John, it's time for dinner. He's like, it's 4 o'clock. And I was like, and then it was like 6 o'clock and I was like, this is bedtime. He's like, it's 6 o'clock. He goes, this time change is really messing. I was like, I think I'm gonna take a nap.
Yeah, I messed that too.
I saw that meme where the lady like looks outside and she's like, is it midnight? Is it midnight?
Yeah,
And
shit.
that's what I was like, that's what you just remind me of. And
That's
he's
what I
like,
just did.
it's like 5 o'clock.
That's what I did yesterday. I was like thinking it was dinner time. He's like, it's 3:59, and I'm like, unless you just want to.
I took a nap before I went to work. And I woke up and I was like, oh my gosh, it's so dark, I must be late.
And then that's 5. That would be the only other option is the 20th.
This is really This one's the sexual differentiation.
I have no idea.
Probably would stay awake for this.
I wanted to try, but
Oh,
I don't know.
I just asked him.
I heard from somebody who told somebody else that somebody else said.
He said that turning it would not be a bad thing.
I don't even see the post where we can turn it in on Blackboard.
Oh, we're
He's not doing it on Blackboard, he's emailing it.
Yeah, we have to email it.
I hate that because last semester I overlooked it. But a read receipt now, it's a whole, like,
He's not gonna force the turn it in thing.
yeah, but he has to make one for it to be free to us.
Right, but I'm saying he's not doing it.
I
He's not the paper. Because he said if he doesn't get it done by the end of class, but he just said it's not a bad thing because somebody told him about it. It wasn't like it was his idea. He said somebody. I don't know who somebody was.
Yeah.
I don't know what it means.
Oh my god. Let's see what the recipes for the day are.
Rachel.
What? Y'all keep calling my name and I just
I only call your name one time.
We go to our new facility.
oh man.
What section do we go to?
It's on the 3rd floor.
What is it? For everybody? Primary care?
Primary care on the 3rd floor. Well, that's where my team is. Yeah, your team's gonna be on the 3rd floor too. And it's in the same spot as my team. What you do is when you come off the elevator, you head the late.
Now, today I'm going to put for an appointment.
Can I say something?
I have to work on the
Okay, Taylor, you
clinic side.
failed.
That's where my
Okay, Taylor, you fail.
So, you know where that is?
I've not been there, so I don't know anything. I heard.
So if you're looking at the facility,
Ha-ha, turn it in.
right, it's park over there. I got lucky tonight. That's good. I got my shot. I feel like I should go down there ahead of time, just so I know where I'm going. Because I go next week.
good
I mean,
lord.
as far as the drive? Yeah. As far as soon as you pass Old Rick Road? Yeah, it's kind of like within half an hour of that. You know where Old Rick Road is? It's kind of like they did some, so like if you go all the way down Scotland, and you go right on, keep going. Okay, and I should see it. I'm gonna see it.
All right, so let's get started again. So,
7 minutes?
I'm gonna figure out this whole turn it in nonsense, and I'll accept papers until Friday without penalty. You can send me your papers by email if you'd like, but I'll get the turn it in thing turned in up and running as soon as I
It's
can.
never gonna be the same, you know that, right?
I'm going for sainthood.
I literally
Thomas is taken, but I'll be Saint Thomas the Merciful instead of Saint Thomas the Doubter, right? No, okay.
Thomas for president.
Okay, so let's go on to newborn screening, shall we?
Yes, we shall.
Friday by 11:59.
Do it.
Yeah. Okay, go sit down. Now, let's talk about happy birthday, right? So let's talk about newborn screening. So we talked about this briefly last week about all newborns or all states in America have required newborn screening for every newborn. So every newborn at 24 hours old or 24 hours after they've had protein for the first time gets screened. Now, we're looking for metabolic disorders, hematologic disorders, and endocrinopathies like hypothyroidism and that sort of thing. And every state has different requirements based on their based on what their states see most often, right? Based on the what's the word I'm looking for? Not the frequency, the
Manifestations?
the rate, there's a word and it's blank and it's right here. Do you see it?
Yep.
Oh, I can't get it.
I just can't read it from here.
I can't read it from that distance. Anyway, if you want more information, you can go to this page and get more information about it. But what's important is that any baby who comes up positive is going to be referred to a specialist for treatment. Okay? These are some of the newborn conditions, some of the metabolic conditions you'll see. Phenylketonuria is the most common one, and a baby with PKU, phenylketonuria, is lacking a protein, an enzyme that's necessary for breaking down proteins. Okay, the book talks about eliminating proteins in formula and breast milk. They're a little wrong. You can, of course, breastfeed a baby with PKU. What they generally recommend is you give them 10 to 20 cc's of protein-free special PKU formula, and then you breastfeed them to satiety. And that will give them the breast milk, but they won't have as much breast milk as they would if you just gave them straight breast milk. And so, it's awful, right?
Like, okay, just out of like response, I had some on my finger once because I was
Yeah.
having Reese's milk.
Sure.
And I just like looked at it and I was like, God,
Yeah.
it smells horrible and it tastes even worse.
And if you remember when we were talking about, when we were in nutrition, and we talked about children with special diets, how they often grow up scrawny and malnourished looking, but they don't achieve their full potential, and that's because of bad management in the early days. And this is an example of it. When you say a baby with PKU can only have formula, you've deprived him of the healthy stuff that's in breast milk besides the protein. And so we want to try to strike a balance. We want to give him enough calories to grow, but also give him the importance of breast milk at the same time. So it's not that breastfeeding is contraindicated, it just has to be very closely monitored. And they have to stay on this PKU diet their entire life. There's a pku.org that I was on checking out, looking for some good information. And there's several articles on there about people who are, the importance of managing the PKU diet after the age of 25, that they continue on it their whole life. They're always missing the enzyme. You have to, exactly. They just can't eliminate the proteins. Then there's galactosemia. Galactosemia is a baby who cannot handle galactose. That means they can't have breast milk. It is incredibly rare for a baby to be born with galactosemia. It happens, but like less than 100 times, period. It's very rare to have galactosemia. A lot of people say, I was born lactose intolerant. We were talking about that this morning in my freshman class. You were not born lactose intolerant. Shut up. You wouldn't be alive today if you couldn't take lactose. But 70% of adults are lactose intolerant. And no mammal drinks milk, period, after infancy. No mammal. Humans are the only ones who drink milk after infancy, and most humans can't tolerate milk after infancy because they're lactose intolerant. Okay? Here in the Western world, dairy products are such a part of our diet. We've maintained our ability to break down lactose, but in other, in the outside of the New World, so to speak, not so much. The further you get away from America, the more likely they are to be lactose intolerant in adulthood.
But then they do yogurts and cheeses though.
They do. They do. Yeah, but they're in small portions, not large portions, and they have the lactose broken down into some other form of sugar through the making the yogurt process. Okay. Then there's maple syrup urine disease, and just like it sounds, their urine smells like maple syrup. And a lot of people get confused because a lot of babies' urine smells sweet, but it's not sweet like this. Okay, it actually is more like maple syrup. Okay, homocystinuria, which has problems with vitamin B6, and then biotinidase deficiency, again, has certain problems with vitamin B6. What's important to know about these is that we screen for these in their newborns, and if they have them, they need to be referred to a specialist. I don't expect anybody to say, you know, oh, to know the difference between a biotinidase deficiency and homocytinuria. I don't expect anyone to know that. Just to know that a baby with a positive newborn screen, what do you do next? Refer to a specialist. Okay? Infections of the newborn, herpes is the most common infection, and it's usually HSV2, and they get it through vaginal birth with exposed mucous membranes. Understand that herpes is passed by direct contact, and so they get it through direct contact. Any mom with a history of herpes it goes on antivirals through the last month of her pregnancy, from 36 weeks to delivery. And we ask very carefully on admission, do you have any prodromal symptoms? Any itching, any burning, any tingling, any blisters, anything at all? And whether they say yes or no, we do a speculum exam at birth, which is really difficult to do when you admit a woman in labor and she's contracting and you've got to do a speculum exam and look at her cervix. But we look specifically at the cervix and the walls of the vagina or the birth canal looking for herpes lesions. And if they have any active lesions, we recommend a C-section instead of vaginal birth. Because if they get this infection, it gets in their eye, they can go blind, or it can spread to their brain and cause herpes encephalitis and kill them. So we do not recommend it. Herpes looks just like a cold sore, but on other parts of the body. And a newborn can get it pretty much anywhere, but they usually get it in and around the mucous membrane somewhere. Okay? And the nursing care is to them acyclovir. I've had one baby born through a mother who had a vaginal birth with herpes. She didn't know she had herpes. And the day after the baby was born, she was like, I got this itching burning on my vagina. Can you take a look? And I looked and went, that's herpes. Boy, this look she gave Dad. But that baby goes immediately to the NICU for 14 days of antiviral therapy, just in case, because she had a new infection of herpes on her labia. Okay? Now, neonatal sepsis. Neonatal sepsis is the most common cause of death in an otherwise normal baby. Okay? Meaning not congenital deaths, not prematurity deaths, but just your average normal baby. They're going to suffer with neonatal sepsis, and it's what keeps pediatricians the most busy in the first 72 to 96 hours postpartum. And it is almost always we blame group beta streptococcus. Okay? Remember the article I gave you guys about the management of GBS and how we screen every pregnant woman at about 36 weeks for GBS with a rectovaginal swab to look for group beta streptococcus, and then anybody who's positive, we treat them with penicillin while they're in labor. Okay? If they don't get penicillin, they are not adequately treated, period. Give them vancomycin, give them ampicillin, give them some non-penicillin drug. It doesn't matter, they're not adequately treated. The pediatricians do not consider anything but penicillin a therapeutic treatment. So when we have our women who are penicillin allergic and we have to give them vancomycin or clindamycin or something else, the pediatricians don't care. They treat them as though they were untreated. Okay? And those babies get extra monitoring.
So solely penicillin is the one?
Penicillin is the only one.
Okay.
Now, it's not the only one that works. It's just the only one that the American Academy of Pediatrics will accept. Okay? It's the one with the most information. But a baby who has neonatal sepsis, there are two types. There's an early onset and a late onset. Okay? And they both present pretty much the same. The difference is GBS sepsis in the early onset baby in the first 48 hours is pretty darn dramatic. But just as many babies will die at 10 to 24 days postpartum as will die in the first week postpartum from neonatal sepsis. I just don't want you to think that once they leave the hospital, they're no longer at risk. They are. They're at risk their entire first month. Okay? So, signs are behavioral changes. Does this mean they don't go out to the club as much? No, it means that they start to become lethargic. They start to become less active. They look like somebody who has flu-like symptoms, right? When you guys get sick, you don't come into work or come to class. You call in sick and you sleep on the couch all day, right? Same thing with newborns who are sick. They do the exact same thing. Their activity level decreases greatly. They struggle with hypothermia, lethargy, hypoglycemia, poor feeding. All of those things are related. They're just like, oh, I feel like crap, and I don't want to eat, and I don't want to move, and I don't want to do anything. Okay? And you prevent it with good hand washing and manage your GBS, and pay attention to your invasive procedures. Try to minimize them whenever you can. We maintain good intake and output. We give them our antibiotics. Usually it's ampicillin and gentamicin. And we monitor their cardiorespiratory status and their sugar status. And it's really important with a sick baby is to minimize their energy expenditure. Don't let them, work really hard to breastfeed, and don't do constant sticks for blood draws. Don't do things that are going to stress them out routinely, because when you do, every time they use energy, they're taking away their resources that allows them to fight the infection. Okay. Let's talk a little bit about developmental delays, specifically neonatal abstinence syndrome. I sent out that article about neonatal abstinence syndrome, talking about the lived experience from mothers, bless you, who have babies born on neonatal abstinence. It's a very interesting idea, right? So neonatal abstinence syndrome is the baby is born addicted to something, and then they have to go to withdrawals when they're born. Crack cocaine, methadone. They're born addicted to Methodist. I can't wait to be a monarch. No. Methadone, cocaine, Percocet, cigarettes, painkillers, even SSRIs. Okay, they can be born requiring everything. Because remember, they've gotten most of these elements all the way through their pregnancy. Their body's gotten used to them. All of a sudden, you stop. If you take SSRIs for 9 months and then you all of a sudden stop, I promise you'll be miserable for a while. You can even have a psychotic break. And so we don't do that to people. We make them wean off of their SSRIs. And so, but we can't do that to a newborn. So there's a neonatal abstinence score that's very much like the neonatal pain score. And the nurse is expected to check them several times a day. I think it's every 3 hours, every 4 hours. Looking for signs of neonatal abstinence. What's really interesting is, when do these neonatal abstinence scales start to become positive? Are they there at birth? No, right? Because they still got the drug in their system. It's going to come later, 12 to 36 hours postpartum, or 12 to 36 hours of life. That's when they're going to start to experience it. So at WOMAC, any baby born with a maternal history of an addicting structure or substance like Percocet or cocaine or like methadone, baby stays with the mom for the first 12 hours and then goes to the NICU for monitoring for the next 72 hours to watch them for their neonatal abstinence. And if they don't have severe abstinence syndrome, then they can go back to the mother. But if they start to score positive, then they watch them very closely. And those babies are often sedated to allow them to kind of work through that withdrawal process without suffering too much. But we keep them in a quiet, dark place. We provide comfort measures and make them feel as good as we can. And we use medication to treat them. And it's no different than you would with a grown-up. The problem is a newborn is neurologically immature. They can't handle the strain of neonatal abstinence, and they can go to apnea, they can have problems with their blood sugar and cause brain damage. They're not quite as strong as a grown-up going through withdrawal, so they tend to suffer. And it's becoming worse, not better. Now, sudden infant death syndrome. Sudden infant death syndrome is often confused. There are several categories of sudden infant death. And they all tend to be lumped together under this big umbrella term, sudden infant death. But there's a lot of controversy surrounding it, because sudden infant death syndrome is unexplained. We don't know what it is. Okay? It can happen to anybody, just like sudden cardiac death can happen in a high school basketball player, goes up for a layup and dies mid-layup, right? It can happen. We don't know why. It just stops. And it often gets confused with rollover injuries and infant suffocation injuries, which are caused by the parent or the care provider rolling over on the baby, or baby is in an unsafe sleep environment and gets his face covered by a pillow or something, and they suffocate. Those are not the same thing as SIDS. Okay? Now, the big push initially was most babies who were dying of IUFD, or who were dying of SIDS, were not actually dying of SIDS, they were dying of accidental suffocation. And they said, well, we're going to fix it with a back to sleep campaign. And so they said, everybody goes back to sleep in their own bed, on their own firm sleep surface, that kind of stuff. And that made the SIDS rate drop dramatically. Did it really make the SIDS rate drop dramatically? No. It made newborn death drop dramatically, because all of a sudden there was very few accidental suffocations. okay? But accidental suffocation is not sudden infant death syndrome, okay? They're two different problems, okay? So the Academy of Pediatrics continues with their their back to sleep campaign, and they are, for whatever reason, 100% invested in the idea that back to sleep is the only safe sleep surface. And so they recommend back to sleep for every sleep. That means a baby sleeps on their back, never on their stomach, okay, until they're able to roll over on their own. An infant who can roll over on his own, it doesn't matter what position you put him in, they're going to sleep wherever they feel like it. But we start with back to sleep. Now, it's interesting, when they first came out with back to sleep, they hit it so hard that we started to get babies with toaster head, with a flat head, because they never spent any time on their stomach. And they were always on their back, and they literally got a flat head, okay? And we had to start like putting bands on their head to reshape their head. And so they had to come out with a modification, and they went back to sleep, front to play. So anytime they're awake, you roll them over on their tummy. When they fall asleep, you roll them back on their back, so that they develop, they can turn different positions. Okay, they need tummy time. Firm mattresses, meaning no water beds, no recliners, no sofas. Nobody has water beds anymore. But when this came out, there were an awful lot of water beds. Keep the newborn in the parent's room, not in the parent's bed. Remove all soft objects, loose bedding from the crib. That means crib rails and little triangle-shaped devices and pillows are all removed from the crib. Decrease smoking in pregnancy and in the house of the newborn. Offer a pacifier at nap time and bedtime. And don't let the newborn get overheated. So these are the back to sleep, the safe sleep per the American Academy of Pediatrics. Okay. Now I sent you guys a couple of articles, and if you read through them, what you'll find is the American Academy of Pediatrics is misguided at best and negligent at worst, because they are purposely ignoring several really good studies that contradict their opinion. And so in their back to sleep, they did it in 2005, they repeated it in 2011, and both times they purposely ignored these really good articles that said that they were wrong. Okay, that's not good science. Okay, but they're invested in it, and no one really can understand why. But what we've discovered is that a newborn, that the real risk factors are smoking and formula feeding. Those two things cause sudden infant death syndrome. Okay, now nothing's going to prevent, the formula feeding isn't going to prevent the accidental suffocation. Okay, it's a different disease. When you're talking about SIDS, the two most prevalent factors are sudden infant death syndrome, is formula feeding, and smoking. Smoking, fairly obvious, right? They've got bad things going into the lungs all the time. So moms who smoke, dads who smoke, anybody who smokes around a baby increases their risk of sudden infant death syndrome. Why do you think formula feeding would increase their risk of sudden infant death syndrome? Any ideas? Besides the idea that formula is poison.
Too much air, lack of...
How do formula-fed babies eat and sleep?
On their back.
Okay, so they eat on their back, and do they sleep for an hour or two? They sleep for much longer times, okay? Because they get large boluses of fluid or large boluses of meal, they have long sleep periods in between that enables them to achieve a deep sleep. And the theory is that they get so deep into their sleep that they can't recover and that they just go downhill, okay? That formula feeding has a sedating effect on newborns, and it sedates them to the point where they stop breathing, which, by the way, is how pacifiers work. Why pacifiers at nap time? Because a baby who's constantly sucking on something doesn't get into that deep sleep that they would without a pacifier. And so pacifiers keep them just a little bit alert and keep them out of that REM 4 or keep them from getting into that deep sleep. And so formula feeding, the theory is that it sedates a baby too much and puts them down. And pacifiers will help keep them awake just a little bit. Right, exactly, because they're neurologically immature. And so that's the thought about SIDS. Now, let's talk about accidental suffocation of the newborn. Accidental suffocation is not the same thing as SIDS. It is not caused by formula feeding. It is not caused by smoking. It is caused by rolling over on the baby or dropping the baby into an unsafe sleep environment. And they really need to be two very different protocols. One is a neurologic thing where they slip into too deep a sleep and don't recover. They have that apnea that just doesn't recover. The other is an accident of the caregiver. Okay? Now, there are dangerous places to sleep with babies. Okay? And as a general rule, there are 4 places. 1, there are 4 rules to sleeping with a newborn. 1, nobody sleeps with a newborn except for mom and dad. Okay? Mom is specifically studied perfectly safe. Dads are, we assume, safe. Okay? And the idea is that, that parental caregiving instincts protects babies. Babies who sleep, women who sleep with their babies. Anybody in here sleep with their baby?
I did.
Okay. When you slept with your baby, did you sleep on your back? No, you slept on your side, right?
Mm-hmm.
Curled up around that baby like this. Okay? With your knees bent. Okay? Like that. What is that position doing for the baby?
Protecting.
You create a cocoon around the baby that protects him against everything, right? But with this arm up, you can't roll over on your side, okay? With your arm and your knee up, you can't roll toward your baby. Your body won't let you, okay? You come up like this, and you try to roll, and you can't. You're stuck, all right? So that cocoon cuddle that moms do when they sleep with their babies prevents rolling over on their baby. And several well-done studies where they videotape women in bed with their babies, every single one of them sleeps like that. Okay, curled up into this motherhood cuddle around her baby, and she can't roll over on her baby. So it's always the mother. Now, aunts don't do that, uncles don't do that, babysitters don't do that. Only mothers do that. Okay, and it's an instinctual sleeping pattern that we develop with our babies. Okay, so only the parents. The other one is nobody who is sedated or under the influence gets to sleep with a baby. No drugs, no alcohol. Okay, anyone take a Percocet after a C-section? No. Anybody taking alcohol to bed? No, they don't sleep with their baby. When we've got newborns and I want to get drunk, I sleep on the couch. I don't sleep in the bed with my baby because I could roll over on the baby. I'm too sedated to respond to my paternal instincts, right? Nobody in the house can smoke. And then because smoking increases our risk just in general. And then the last one is always on a firm, flat, familiar sleep surface. So, being in the hospital with your newborn the first 24, 48 hours of life, no, you don't sleep with your baby. It's not a familiar sleep surface. Okay? At home, on your bed, perfectly safe. But not on the couch, on the recliner, in a rocking chair. Those are very dangerous positions. Okay? The couches and the recliners tend to be overstuffed. And so baby slips down between the cushions and dies because they suffocate. What's an interesting problem with the Back to Sleep campaign is that you've got these exhausted parents getting up in the middle of the night, and in order to avoid sleeping in a dangerous place with their baby, they go lay down on the couch or they sit in a recliner, and what happens? They drop the baby into the sleep, in their sleep into the couch, and the baby suffocates. Okay? And unfortunately, in the eyes of the American Academy of Pediatrics, they lump that together with the breastfeeding woman who's sleeping in a firm sleep environment. And I gave you guys a couple articles. What was interesting was they did a case study of like 168 newborns who died of either sudden infant death or accidental suffocation. And they found that 46 newborns died alone in a crib, and 44 died sleeping with their mother. And they said, see, sleeping with your mother is dangerous. Wait a minute. More of them died alone in a crib. Obviously, you've got something wrong here, right? So look at the studies, look at the numbers. They're very interesting stuff.
What's a correlation? I thought I...
First article I ever wrote was on sudden infant death, or on co-sleeping. I absolutely hate the way the American Academy of Pediatrics does it. And they've threatened to take my credentials away several times. And I go, I dare you to. Go ahead. Not going to do it. What are they going to do? I'm a colonel.
For a little bit longer.
For a little bit longer. Yeah, I got official word. I have to be a major again on this January 1st. Such is life. I don't get to keep my rank when I retire.
Wow.
That sucks.
Because you didn't wear it for 2 years.
Because I didn't wear it for 3 years.
3 years.
Yeah.
Wow.
I didn't know
Because it was more important to come see you guys and teach you than it was to go be a colonel for another year.
You could always go to reserves.
Retirees don't go into reserves.
Hey.
No.
You did.
Well, I wonder. Okay.
No,
So-
it's just the top 3. It's okay. You're fine.
Yeah, I get paid the same. It doesn't matter. It's just what they call me.
Oh.
That's okay. As long as they don't call me late for dinner, I'm okay with it. So, respiratory distress syndrome. Respiratory distress syndrome is exactly what it sounds like. Usually it's premature infants who don't have surfactant. Okay? The signs and symptoms are just what you see. Expiratory grunting. Every time they breathe. Okay? You'll hear babies run. They're in trouble, right? Nasal flaring, cyanosis, rapid breathing. Labored breathing, you'll see retractions in their ribs. You'll see their ribs very clearly lined out. And then decreased breath signs, oftentimes with rales. So you listen and you don't hear them breathing deep into their lung bases. You can hear them breathing up here, but you can't hear them breathing down there. And it means they're just not filling their lungs and oxygenating. Yes?
Well, I'm just trying to think of the sound that you would hear when you're not supposed to walk, the transportation sound you would actually hear. I'm just trying to think because you're just.
Well, it usually sounds just like normal breathing. You know, it's a, if they've got rails, if you take your hair and kind of curl it around your ear,
Oh, that's right.
you'll hear that crackling sound.
Yes, yes.
They tend to sound like that.
Okay. Oh, that's the rails. That's what the rails.
That's
sound
rails,
like.
right.
Okay, thank you.
The trick for RDS is to make sure they're on humidified oxygen, giving them, you know, whatever mechanical ventilation they need, depending on how bad they are. Okay. Nitric oxide. Did anybody read anything in the book? Did you read anything about nitric oxide?
Nope.
It's a vasodilator. So it increases blood flow to the lungs, and it opens up the alveoli, and it makes them easier for them to accept air. So we have them breathe nitrous oxide for a while. And ECMO. ECMO is a heart-lung machine for a newborn. They actually take the blood out of the body, oxygenate it, put it back in the body. It requires 3 nurses to take care of every baby who's on ECMO. It's impressive stuff. It is absolutely worst-case scenario. I've never met anybody who's done it, and I've never met anybody who's survived it. ECMO is a very impressive thing to do for a newborn. It's definitely the last effort. Apnea of prematurity. Very common for premature babies to have apnea spells. As a matter of fact, most hospitals have a discharge criteria that they have to have 7 days without apnea or bradycardia. And so these babies are very closely monitored for apnea. And apnea is any pause in the breathing that lasts for more than 20 seconds. But they will tend to have, abruptly they go pale. They'll like look like they pass out a little bit, turn blue. Bradycardia goes along with it, and they desaturate. And what do you think the treatment is for apnea? Stimulate them, wake them up. Okay. I've spent very little time in the NICU, but I was in the level 2 NICU once. I got floated there as a labor and delivery nurse, and I was in the feed and grow room, and all I had to do was monitor the babies and just make sure that they got fed at the right time. And the alarm went off, the apnea alarm went off, and I was like, nobody told me what to do for apnea. I didn't know what to do. And I was like, and I thought, well, what would I do if he was in utero? I would just turn him. So that's what I did. I turned him, and he started breathing again. And my wife was like, that's actually all you do. You just, hey, be okay? And they'll start breathing again.
Gotta remind them. Yeah.
So I was like, oh, I guess it works on the outside as well as on the inside. So we pay very close attention to the baby's cardiorespiratory status in the premature babies, and we respond immediately and aggressively with, stimulate them. And then we can give them some drugs, some theophylline, some aminophylline, and some caffeine to help prevent apnea and bradycardia. And then we gradually wean them off when they come close to their due date. BPD is a chronic respiratory distress. It's caused by prolonged time on a ventilator. I believe adults have the same problem, don't they, where they can't wean off the ventilator? Yeah. And you just have to gradually wean them off the ventilator until they're ready to go home. But then, some babies will end up going home on respiratory equipment. It's actually not very uncommon. Jaundice, we talked a lot about jaundice. These slides we've already covered.
That's the dumb slide.
By the way,
Highlight, capitalize, underline, italics.
That's what breast milk is.
nope. Electrolyte solutions are LR. Okay, and this is ECMO. So what you see is they actually pump the blood out of the body, run it through its machine, and put it back inside, back through a membrane lung. Anemia. So it's not uncommon for premature babies to get anemia of prematurity. It's caused by several factors. One is rapid growth with a poor response to erythropoietin, and the other is, of course, repeated blood draws. In the NICU, they draw blood and they keep a tally of how much blood they draw. And then like every 10 cc's or so, they'll replace that blood back, and they give the baby another blood transfusion to replace the blood that they took. I gave one baby a blood transfusion. He needed 10 cc's of blood. And I had to draw 13 cc's out of the blood bank because we were going to waste 3 cc's in the tubing. How precise is that? That drives me crazy that somebody thinks that way. That I need to give him 10 cc's, so I need to draw 13 because I'm not going to give him all 10, right? And so if I'm like,
That's a drug calculation right there.
yeah, that's impressive stuff,
Yeah,
right?
Because when the peds, we had to do an IV through that,
Mhm.
because it was just from the actual syringe, it wasn't even,
Mm-hmm.
so it was, yeah, that was really
Yeah,
interesting.
when you're in the PICU or in the NICU, they routinely use syringe pumps to give their baby stuff. So they give them, like 3 cc's over 30 minutes. It's pretty impressive stuff. Matter of fact, we do that all the time. That's how we give babies antibiotics, is in a syringe pump. But the signs are just like you would see in a grown-up: fatigue, respiratory distress, and pale skin, and a drop in the hemoglobin. And so we just give them more blood. All right, necrotizing enterocolitis. Necrotizing enterocolitis is a major source of morbidity and mortality in premature infants, and it's caused by blood shifts in the lungs, periods of ischemia in the gut, and the babies tend to have portions of their bowel will die. Okay, but they'll have a loss of bowel movement, abdominal distension, increased abdominal circumference, and irritability and lethargy. Okay, and so this is a baby who's got bad bowels, and he's not tolerating feeds very well, and all of a sudden you get this abdominal distension, and his bowels will shut down. And the more you put in, the more problem you've got. So just like an adult who's got an ileus, who now has lost bowel function, we stop feeding them, we put a tube down their throat, and we keep their bowels empty, right? The exact same thing with a NICU baby. If they've got an abdominal distension and loss of bowel movements, you stop everything and get further evaluation. And that's why the answer for that quiz question was make the baby NPO, and then the next thing you would do is call the doctor for more evaluation. But it's incredibly common, especially in the realm of immediate cord clamping of their micropremies. My mentor did a study on micropremies from 24 to 28 weeks and found that there was like a 7-fold increase in necrotizing enterocolitis on a 24 to 28 weeker who had immediate cord clamping versus 30 to 45 second delay. It was pretty impressive stuff. And so that's all going. The other part to neck is giving them non-breast milk. Remembering that the idea that breast milk or colostrum early on closes the bowel and protects it from the outside world. Okay, it's something inside the body that actually has access. You can go directly from the stomach to the anus and never actually into the body, right, by going through the tubes. And so that bowel has to be protected against the outside world, and that's what breast milk does. It closes the bowel, so it causes a barrier between the inside and the outside. And so if you don't give a baby breast milk, they have more problems with necrotizing enterocolitis, which is why Cape Fear is doing a study right now giving breast milk only to their 34 weekers and below. So any baby born below 34 weeks gestation is fed only human breast milk, either from his mother or from a donor. And they're trying to see if they can prevent enough cases of necrotizing enterocolitis to make it worth it.
So what's the link between the milk and the lack in blood circulation that causes the necrotizing in the intestines?
I think that there are two parallel paths that both help. That's not that they're created. They're not that they're linked. It's that they both help. So if you do immediate cord clamping and formula feed your baby, you've given them a 1-2 punch, setting them up for more necrotizing enterocolitis. Okay? So what you do, the nursing care, is to measure the abdominal circumference, auscultate for vowel sounds, and check for aspirate. So before you feed a premature baby, they have a tube down into their stomach, because they usually feed them through a tube instead of making them suck. Because sucking babies who are less than 32 weeks, they can't suck very much. It uses a lot of energy to suckle. So they tube feed them almost exclusively. And they check for residual before they feed. And if the residual is more than like 20% of the feeding, the baby doesn't get fed. They wait. because they've got too much food in the bowel already and they're not using it for whatever reason. Okay? So we check for residuals using our gastric feedings. Watch their bowel movements and look for blood in the stool. Okay? Gastroesophageal reflux disease. In my opinion, not so humble, horribly overdiagnosed in normal newborns, but very, very common in premature babies. Again, that decreased neurologic abilities, decreased musculoskeletal capability means that they're going to have a weak pyloric sphincter and they're going to get more gastroesophageal reflux disease. So they'll get these symptoms: frequent spitting up or vomiting, irritable when feeding, refusing to eat, they only eat small amounts, they arch their back and they complain, they regurgitate, they hiccup or cough all the time. Why would they, bless you, hiccup or cough all the time?
Because of the acid.
Because the acid reflux is in there. It affects their what's that thing called? The epiglottis, thank you. Frequent waking during sleep, again because of the burning of the acid reflux, and respiratory problems as they reflux into their lungs and get little bits of infiltrate. Okay. The important thing is to look for aspirates in the nasogastric tube if you're tube feeding. Using thickened formula or breast milk is a little controversial. If you've got a baby who actually has a problem, then yeah, thickening it a little bit can help. But what's often happening is you're formula feeding a baby 3 times more than they need and they throw up, and you go, see, he has GERD, and then you thicken it, and that doesn't help. Okay? There's some pretty decent evidence that if you give a baby rice cereal before they're 4 months old, they are more likely to have allergies as they age. And so we don't want to give thickened formula or thickened breast milk to anybody who doesn't need it. And the question always becomes who needs it and who doesn't need it. So you have to be careful with your diagnosis of GERD. Placing the infant at 30-degree angle for sleeping and feeding in an upright position very slowly is very useful. My favorite breastfeeding position for a baby with GERD is to have him sitting straight up on mom's lap and just kind of lean him into mom. So he is right up on top like this. He's not laying down. So he sits up top and it kind of runs down better. Okay? We can use protein pump inhibitors to neutralize the stomach content. Makes it easier on the babies. That doesn't stop them from regurgitating, it just stops the acid from coming out, right? Retinopathy of prematurity. Has anybody heard of retinopathy of prematurity ever? No? That's because it doesn't happen anymore. But it used to happen all the time, okay? Before we figured it out. One of the complications of being born prematurely was you would go blind. And what it is that oxygen is a free radical, and it damaged the retina in the small blood vessels in the eye, and it made these premature babies go blind. So now we know we can control retinopathy of prematurity by decreasing the amount of oxygen we give them. Give them the bare minimum amount of oxygen they need to keep their stats up, but don't give them any extra oxygen. If you pay attention to a baby who's getting a neonatal resuscitation at birth, you'll see that they don't use oxygen. They use free air. They don't use oxygen to breathe for their babies. They just use a regular pumper, not connected to oxygen. Because we don't want them to have excessive amounts of oxygen because it can cause that. And the only way to diagnose it is to have an ophthalmologist come in and take a look at their eyes. And they have this really horrific looking device that kind of catches their eyes and opens them so they can look inside the baby's eye, and the baby can't complain about it. But they complain, but they can't do anything about it. But the key to avoiding retinopathy of prematurity is to use very low levels of oxygen, wean them off as soon as possible, avoid bright lights, and shade their eyes whenever they have to have bright lights. If you look in your book, there's a picture of an isolate. Where is it? It must be early in the chapter. On page 719, you'll see a picture of an isolate, and it's just a big box completely covered with a blanket. Okay? That they spend most of their time in a quiet, dark environment, just like they would be in the womb. Okay? In acute intracranial hemorrhage, these are grade 1 through 4, and grade 3 and 4 are the most severe, of course. But it's an intravascular hemorrhage where they get a brain bleed at birth. Again, directly linked to immediate cord clamping. The shunting of the blood causes the weak blood vessels to burst. And so they, the same study, the one that found the decreased risk of necrotizing enterocolitis, found a similar decreased risk of grade 3 and 4 brain bleeds with delayed cord clamping in a 24 to 28 week baby. Pretty impressive stuff. So as we're learning, as we get more experience, we realize that sometimes intervening isn't the best method. Sometimes just kind of monitoring and stabilizing is the best way to help these babies do well. But the signs and symptoms are very similar to a stroke. A decrease in tone, seizure, sudden drop in hematocrit, a full anterior fontanelle where they're bleeding in the scalp and they're filling up between their brain and their skull. Okay? And the only way to check it out is to do an MRI or an ultrasound to find the brain bleed. And our care is head circumference and checking the fontanelles. Reposition the baby at a 30-degree angle to keep the pressure off his brain. Recognizing seizures and observing a change in the neurologic status. Okay? Now, post-term infants are babies born after 42 completed weeks. Clinical signs, things that you'll commonly see in a post-term infant is that they'll have meconium-stained skin, nails, and umbilical cord. Desquamatization, meaning the skin is peeling off. Understand, just like the placenta, the fetal skin isn't designed to last for very long. It peels off right after birth. And so it starts to peel off in utero. And so they get this peeling skin, parchment-like old, worn-out skin. Their fingers look very long, and they have very long fingernails. And people always are like, wow, there's some long nails in that kid. That's because he needed to be out a week ago. Okay. And then they could have generalized muscle wasting from the decreased function of the placenta. Okay. They, of course, tend to have a lot of meconium aspiration syndrome, which we already talked about. And persistent pulmonary hypertension of the newborn, PPHN. Anybody have any idea what PPHN is? Besides the obvious persistent pulmonary hypertension of the newborn. What does it sound like? What is pulmonary hypertension?
Increased lung pressure.
Increased lung pressure, exactly. So in order to make the change from fetus to newborn, from water breather to air breather, what has to happen in the lungs? It has to drop. Remember, the pulmonary vascular resistance has to drop dramatically. And so if they don't ever make that drop in their lungs, what happens with their ability to breathe? It doesn't happen, right? They got this increased vascular resistance in the lungs and it can't come down, and that causes them to not be able to change over to air breathing. Okay? And your book has a pretty decent little graphic of it right there on page 738. But these babies have central cyanosis, grunting, retractions, murmurs, and blood pressure problems. Okay? Let me get to 738 real quick. I thought I put a picture of it in here, but I didn't. So what happens is you have this pulmonary vascular constriction, okay, which causes the pulmonary artery hypertension and vascular resistance to rise. Then you have the right to left shunting through the foraminal valley, because with the blood backing up in here, it's not able to make that change. It's not able to close that door. So the blood is shunting back and forth. So now you have oxygenated blood mixing with deoxygenated blood as it leaves the body, which was perfectly okay for the baby in the uterus, but not okay for the baby on the outside who now has to oxygenate on his own, right? That ends up leading to hypoxia because you've got this blend of oxygenated, deoxygenated blood, and metabolic acidosis, which causes vascular constriction. So it becomes a cycle and it gets worse and worse and worse. What do you think the treatment for it is?
Oxygen?
Nitric oxide. Why nitric oxide?
Because it's a.
Because it's a
Oh, what did you say?
vasodilator, exactly. So it's going to drop the vascular resistance and in the lungs and cause the system to drop. Once the pressure drops, then the lungs can, then the foraminal valley can close and start to establish external pressure, external breathing. Make sense? And last ditch effort, put them on ECMO. Okay? Bad stuff. Did I go backward? I went backward. Newborn screening, why are these coming up again? Okay, so other problems. So we talked about these, right? The PKU, galactosemia, that kind of thing. Now let's talk about the endocrine conditions. I don't know why they put them in this order. This should have been used earlier on. But a baby who has hypothyroidism is going to have the same problem as a mom who has hypothyroidism, right? So he's going to be hypoactive, he's going to have lethargy problems, poor feeding, constipation, a hoarse cry, hypotonic reflexes, and he's just kind of slow. He's not going to grow very well. He needs to be put on his on some Synthroid. His labs are going to be just like the grown-ups. He's going to have a low T4 and low T3. And you just need to, teach him that he's going to have lifelong thyroid needs, lifelong replacement. Neurologic conditions. All of these are 1 degree or another of, well, most of these are 1 degree or another of neural tube defects. Okay. Spina bifida is the one you hear about the most often, right? And that's a defect in the spine, usually around the tailbone, but it can happen anywhere along the spine. And there are pictures, if you look hard enough, you'll find pictures that go from the tailbone all the way up to the top of the back, where the spine is open. Okay? Obviously, that child is not going to do as well as a kid who just has a little defect at the tailbone. Anencephaly, anen meaning no, cephaly meaning brain, no brain. Okay, a baby with anencephaly has a brain stem, but no brain. Okay, and so the upper portion of the brain is all missing. They survive in utero just fine because they don't need a brain in utero. Okay, all they need is a heart, and then a heart and a placenta, and that keeps them alive. But when they're born, they need brain function. They need that neurologic shift, and they don't have it, so they usually die shortly after birth. Anencephaly is a condition not considered compatible with life. Although there's a recent feel-good article about a baby with anencephaly who's now like 18 months old. And if you want to see something that's really unsettling, do a Google search for images of anencephaly. Babies have normal faces with gigantic eyes and missing head. It's like comes down and here this whole thing is empty. It doesn't ever form a skull. There's just no skull to them. They just open in the back of their head. Very bad. Okay? An encephalocele is a small protrusion of brain through the skull, through that little hole in the base of your, what is it called? The magnum, the
Oh, yeah, that one.
Magna Carta, right. No, the
Foramen
foramen magnum, I think is what it's called.
Yeah.
Where it herniates through that hole, so their brain is in their C-spine instead of in their skull. Okay. Microencephaly is smaller than normal head, which can be a problem, but it can also be that, funny-looking parents have funny-looking kids. And holoprosencephaly, where the cerebral matter fails to form as two distinct hemispheres. And these are it's not compatible with life. Okay. Gastrointestinal problems, cleft lip and palate, extremely common. You can have a cleft lip and palate. The cleft lip, of course, is just a defect in the lip. Okay. A cleft lip and palate is when it extends all the way back into their hard palate up on top. And they're very easily surgically repaired. They're not a big deal. Now, it used to be, and we worry a lot about feeding for those babies because they don't bottle feed very well. But guess what they do very well? Breastfeed. They breastfeed extremely well. I've never met a baby yet with cleft lip and palate who couldn't breastfeed. Okay? Why? Because they've got, the problem with bottle feeding is they've got these holes right here, right? And so their lips can't form a seal. So they can't bottle feed. But guess what happens when you have a proper latch? It looks like this. Sealed. Done. So they press into the face, and the mother's breast closes that problem here, and then babies can breastfeed very well. So cleft lip and palate is a feeding problem from a formula feeding perspective, okay, not from a breastfeeding perspective. But they need very careful monitoring to make sure that they're able to form a seal, that they don't have an air leak. And usually if they do have an air leak, I just press down on the breast a little bit more and close it. So they're like going, and you hear a little, and then it's gone. You just press it down a little bit and it closes the air leak. Pretty neat stuff, right?
Can they drink from cups?
What's that?
Can they drink from cups?
Oh, sure. Just pour it
That
in
would be a
because they don't require any kind of suction.
Yeah.
Yep. But yeah, your book has a picture of a Haberman feeder, and a Haberman feeder is it's on page 743. It's a regular bottle with a very tall nipple, very long, that it goes past their mouth. and goes right back to the back of their throat. So it kind of closes it off on the other side of the thing. Again, I've never had to use it in a breastfed baby. But the important thing is to maintain adequate nutrition. And when you have a baby who has surgery, yay, it finally came. That's yours.
Well, if you don't want it now.
That's okay.
Thank you.
We've only been waiting for it to come all day. Okay. So the important thing to understand about it is these kids are going to require surgical intervention, and so you're going to have interruptions to breastfeeding, and that's okay. And it might be that they can't feed for a couple of days because they've got a sore face, and mom just needs to pump, and we give him food in an alternative route until he's ready to go back to breastfeeding again. But it has very little problems in the breastfed baby as long as you're paying attention to breastfeeding. Okay? And then, of course, it talks about emotional support. Very important to understand that everybody wants their baby to be beautiful and perfect. And so a baby born with a cleft lip is a big blow to moms, right? My baby's not beautiful. And so he can be beautiful. He can. It can take a little bit. And we'll fix him and he'll be fine. So a little emotional support. Okay? Anytime the baby's not perfect, mom and dad need emotional support. Respiratory problems. Congenital diaphragmatic hernia. Any idea what that is?
Something happened.
A hernia in the diaphragm, right? And so what is a hernia but a defect in a muscle, right? So you get a defect in your diaphragm and allows the bowel up into the lungs. Okay? So if the chest fills up with bowel, guess what it can't fill up with? Lung. Okay? So babies with a congenital diaphragmatic hernia often have underdeveloped lungs because they've got bowel in their lungs instead. And so they tend to struggle with breathing. If it's a minor problem, we get the bowel down out of the lungs can develop. If it's a major problem, it'll fill up the entire thoracic cavity with bowel, and the baby will never develop lungs, and obviously they have a little bit of trouble surviving if they don't have lungs, right? But you'll notice, if it's real small, you might notice it with diminished breath sounds. The baby will look like he's got some kind of a collapsed lung or something, where he's not breathing very well, or he doesn't have even chest rises, and it's because his right lung never developed because the bowel is in there. Okay? Or it happens at birth, it breaks through, and he's got bowel up in there and his lung can't expand. Okay? What's that? Yeah, we can take a break.